Welcome to the ABCs of MIPS, our monthly broadcast looking at how the merit-based incentive payment system will impact your bottom line. I'm Carol Flagg of High Tech Answers. Thanks for joining us. On this program, we address your questions covering the full spectrum of the payment program, including MU, PQRS, BBM, MACRA, and of course MIPS. On today's program, we address the newly proposed rule for MACRA and MIPS. Our expert from SA Ignite is Beth Haug, VP of Client Services for SA Ignite and a national expert on meaningful use, MACRA and MIPS. Beth, welcome to the program and thanks for joining us today.
Thanks so much, Carol, and thanks for the nice introduction. I think Carol gave us an especially short introduction in order to make sure that we maximize the amount of time spent on a whole lot of legislation. So, just to kind of set the stage, an overview today, I'm going to give an overview quickly of MACRA itself. If any of you have been attending these webinars, then certainly you've heard us talk about MACRA generally. Then I'm going to dig in quite a bit more on the MIPS, merit-based incentive payment system, specifically around eligibility, financial impact, and all of the different components. So because of the proposed rule that has come out, we have a lot more detailed information than certainly what we knew prior to that. And then at the end, as usual, we will have some Q&A. I expect that the presentation itself will take up a bit more time than our usual 30 minutes and then 30 minutes for Q&A, so you may see us going closer to 45 before the Q&A starts. So there we go. I can advance my slide. Okay, just a little overview here. So as you remember, if you want to Google the description, it's always good to have the full name of it out there. The Medicare Access and CHIP Reauthorization Act of 2015, in short, was the act that really repealed that SGR formula, not a formula that anybody was very fond of, because it required every single year for Congress to come out and tell doctors how much money was going to be potentially cut from their Medicare bills for Medicare charges. So when this new MACRA Act came out, it was passed with an overwhelming majority and basically takes that old way of thinking about this, that goes away, and then the new way of thinking is all related to quality performance. So what this does is for each provider, Medicare Part B provider, you're placed into some category. The majority, by far the majority, are going to be placed into MIPS. Some are going to be in advanced alternative payment models, such as two-sided Medicare ACOs, so sometimes called Track 2 or Track 3 MSSP ACOs. There are some other things that are considered advanced alternative payment models. And in some cases, both MIPS and APM. So this is complicated. Like I said, the majority are going to be straight in MIPS, and then a smaller portion will be in these APMs. I'm having some trouble moving the slide. There we go. Okay, so timeline. As you know, the draft rule was released on April 27th. As per typical NPRMs, you have a 60-day comment period. So at the end of June, that comment period ends. And what the regulation says is that by November 1st, there's going to be a release of a final rule. And then because we've talked about other final rules that we were waiting to be released sometime in the fall, you'll see that we don't have much of a turnaround time before the first performance year is going to begin in January. Before I get into all of this, I think it's always helpful to see what the new terminology is for these kinds of programs. So one of the things you'll see on, oops, how'd that happen? One of the things that you'll see is that my cursor is moving things ahead a little faster than I expected. I apologize. So one of the things you'll see if you've been on any sort of CMS webinars is that they refer to all of these, and the big nice summary that's been written is as the quality payment program. So the combination of MIPS and APM is the quality payment program. So you'll see that, and it'll be called QPP because we do acronymize everything. The terminology of a CPS, the composite performance score, is the score that MIPS is going to result in. So that 0 to 100 point scale is now going to be called the Composite Performance Score, the CPS. And then meaningful use, as we know it for the Medicare providers, has been rebranded to Advancing Care Information, or at least that's the way I like to think of it, as rebranding. So now I'm going to dive into MIPS. So as an overview, 100-point scale composite of multiple programs. That hasn't changed from the fall. You'll see that the PQRS and BBM programs relatively, as we know them, and there's obviously some significant changes there too, those are rolled into this, as well as the Meaningful Use program in a whole different type of capacity. And then there are a couple other categories I'm also going to describe. So it's going to leverage the rules that already exist. And what I mean by that is the MACRA regulation, for example, doesn't specifically list new measures that it's going to track per se, but it does reference back to the modified stage 2 rule that references the stage 3 measures. So the concept of a stage 3 measure stays the same. It's just now referenced back to that existing rule. It's going to make all of the financial impacts in one place, and I will go through some of the financial impacts so you'll be able to see that, and you'll also be able to see how it increases the financial impact for this program. It has the opportunity to rank peers nationally and report scores publicly. So it also says that, yeah, we can now put a number on each of the providers' heads. They can be ranked nationally based on this 100-point scale. And back to that financial impact, MIPS is budget neutral. There's going to be incentives to winners, funded by penalties to losers. So that concept is a big change from existing programs. So who's eligible? This has gone back and forth a bit, and I think I've seen different questions posed on any number of calls that I've been on around who is eligible. So slight change for years 1 and 2, or the performance years 2017 and 18. They've included the NPs, CNAs, CNs, and CRNAs into that mix. They recognize that that could be new reporting for those groups of people, and so they do have some suggestions in the rule around what could be done to mitigate any concerns for their ability to report measures in the same way that the physicians now report measures. And then in years 3 plus, they have indicated that the secretary may broaden the eligible clinician list. So there's a lot of signals around we're going to make that eligible clinician list much broader than what it exists right now. I think I've heard some people be confused because some of these people are part of the existing PQRS program, but now you're kind of taking a step back and then they'll be part of this program going forward. You'll also lastly note that we do have new terminology. Rather than the eligible provider, it is the eligible clinician. Okay, so who's not eligible? So easy one, any first-year Medicare Part B participant is not eligible. Those people that are below a low patient volume, which they indicate to be Medicare billing charges less than or equal to $10,000 and providing care for 100 or fewer Medicare patients in 1 year. So that's their low patient volume threshold. And then certain participants that are in these advanced alternative payment models. And we highlight the word advanced, and CMS does as well, because I think there was some sense that the alternative payment models more generally would be exempt from MIPS. There's another pretty major difference with participation in MIPS from that kind of the collection of all of the different programs. So as you know, for PQRS right now, you can participate as an individual or as a group, and the group is identified as the TIN. With Meaningful Use, ACI, as they now call it, you only can participate as an individual. For MIPS broadly, they've made it consistent now that you can participate as an individual or as a group. So your ultimate reporting to CMS will be as an individual or as a group for the entire MIPS categories. You have to stay consistent, so you will be reporting as an individual group for all 4 categories. You can't cherry pick and do individual reporting for one category and group reporting for another, and that's a pretty big change. So back to those numbers again, and I think if any of you have heard Tom on some of these previous presentations, then you'll know that the numbers are quite significant, the impact here. So as I mentioned before, this is a budget neutral program, so the losers will fund the winners. The maximum adjustment in 2019 for the 2017 performance year, so there is that 2-year look back, is -4%. So they're not going to ever penalize you more than that. There is the opportunity, though, on the upside for you to get much more than the 4%, and I'll go through that in a minute. They have what they call the adjustment factor, which exists today for the BBM program, and they've indicated that it can be, for this program, up to 3 times whatever the maximum performance is. So in this case, that would then take these people up to a 12% adjustment, a 12% positive adjustment, as opposed to just that 4%. So really, it comes down to how many losers there are relative to winners as to whether or not that adjustment will be in there, and if so, whether it will hit the maximum of 3. So seen kind of a different way, we wanted to illustrate how important each individual MIPS point was. So in the year, CMS will indicate what the performance threshold is for all of the providers. And what they've indicated in the regulation is that performance threshold will be the mean or the median composite performance score for all eligible clinicians. So they're going to set that right there at the 50%, meaning half will be below it, half will be above it. At that point then, the maximum penalty, like I said, will be -4% for all those people that are scoring in the, how do we put this, the 25th percentile of the lowest performers. So if you take this lowest performer and go down, the 25th percentile will get -4%. Same as on the positive side. So besides that 4% bonus, and potentially then, of course, that X factor added to it, there is something called an exceptional performance bonus that can be added on top of this, and that's the 25th percentile above the performance threshold. So again, the numbers start to get very big when you think of the financial impact. Okay, the MIPS components, as I mentioned before, there are 4 components that total up to that 100 points for the composite performance score. So the great majority of those points is the 50% in the quality category, or as we would say, the PQRS and BBM programs as we know them. There's going to be 10% applied to the resource use category, and that's essentially cost and will be calculated by CMS. So no reporting requirement there. There will be 15% assigned to the CPIA, or Clinical Practice Improvement Activities category, and they do have a list posted of what those different CPIA activities might be. So we do have some information there, and that's going to be 15%. And then 25% will be the advancing care information category, or meaningful use as we know it today. So I'm going to start here with the ACI program and dig in a bit more about how it's calculated and what are parts of it. So as I indicated earlier, meaningful use has been renamed, rebranded, it depends on how you look at it, Advancing Care Information, or ACI. So the new terminology going forward for the Medicare participants will be ACI. Having said that, Medicaid MU and hospital MU at this point remain unaffected. I believe I read recently that there is some conversation already going on the eligible hospital side, but at this point, the Medicaid meaningful use program will stay exactly as it exists. For the 2017 performance year, you will be using a 2014 or 2015 certified system. I think 2015 certified system is optional for the 2017 performance year, and your going to be reporting modified stage 2 or stage 3 measures. I believe the stage 3 measures are the ones that are optional with each of those respective systems. Going forward, 2018 forward, you're going to be on the 2015 certified system, and you're going to be reporting the stage 3 measures. So just a high-level review some of the characteristics of the current MU program so that I can really draw the contrast to what's going on going forward. So as we know, right now there are thresholds for measures. There's an all or nothing, meaning you make all of your measures or you don't get anything. So you meet meaningful use or you don't. It's very binary. You have very little choice in what to report. So while there are menu measures, or there were menu measures, and there is some choice in reporting public health, you really don't have much choice what to report. You also do have a CQM reporting requirement. For certain submission methods, you can get that CQM reporting requirement met via your PQRS submission, but in general, you have to report your CQMs as part of your meaningful use measures. There is the notion for both measures as well as people, the notion of exclusions or hardships, exemptions, or people that don't for whom the meaningful use program doesn't apply, and that's handled differently too. So I'm going to talk about that. I pointed this out earlier. The existing program right now is individual performance only, so it is completely just provider NPI based, and Medicaid and Medicare are the same. So going forward, the thresholds for measures, the whole idea of a threshold absolutely goes away. So in the ACI program, there is going to be a base score and a performance score, and everything will be based on your participation in the base and then how well you perform on any of those performance measures. And I'll go through that in a little bit more detail in the next couple slides. The notion of an all or nothing also goes away. So I think during the period before this NPRM was published, there was a lot of conversation about whether or not that meaningful use category would be binary, and it's not. So you can earn up to the 25 points depending on how you perform on the measures. There's a fair amount of choice in which measures to report. So while you have your maximum score that you can get based on the measures you're reporting, you can choose to report less than that in the performance scores. The CQM reporting requirement actually goes away completely. So you will not have to report CQMs at all, and instead those are going to be aligned with other programs, and you won't need to do anything further for that. The way that they're handling exclusions and hardships, and I should probably take them one at a time, is exclusions for measures really goes back to the fact that you can choose which measures to report. So if somebody can't meet a measure because they're a specialist for whom that measure really doesn't apply, then they just simply wouldn't be reporting that measure. If they are a person that can't do any of the ACI category because of some sort of hardship, something that you might at this point file a hardship exemption for, then the regulation says that they can weight the ACI category to 0. So rather than even have a separate process for filing for hardships, instead they're just going to change the weighting, and then the other 3 categories are going to count for that much more as part of the overall composite performance score. Individual performance only goes away, and it now gives you the option to also report as a group. So you can report both individually as well as a group. So if you potentially have, so there's some potential, obviously, analysis to be done to determine whether you should be doing individual reporting or group performing. And then, like I mentioned before, the Medicaid and Medicare programs really then diverge, and they are separate programs for at least a period of time. I'm going to point out a couple other proposed changes that are in the rule. So one is that in the future, they have indicated that they may reduce the overall percentage weight of that ACI category, so that 25% weight might go down if they start to see that 75% of eligible clinicians are deemed meaningful users, and they do use that term, that comes back. So the idea is if most people are meeting that measure, that category, if most people have met the measures as they define it, then they're going to make the weight a little bit lower, and they're going to watch that fairly closely. They have also indicated, and specifically what they were talking about was the addition of the NPs and PAs when they were talking about this, which is if you learn that there are not sufficient measures and activities applicable to those eligible clinicians, then they can assign a lower weight or a weighting of 0. So this is how they're going to handle the hospital-based physicians, for example. People for whom this doesn't apply, then you can apply to get a 0% weighting for the ACI category. And then lastly, I just want to point out we do have something that actually starts immediately, and that is that in calendar year 2016, so for this particular performance period, you're going to see a new point on the attestation page, I think probably at the confirmation at the end, that's going to say that you are cooperating in good faith and haven't done anything to inhibit information exchange. So they're taking, again, that very seriously. They want to continue to push interoperability, and one of the ways they're doing it is requiring you to attest that you haven't done anything to reduce that interoperability. So now let's talk about how to calculate ACI. So ACI itself is 25% of the overall 100-point MIPS score. That 25% is calculated based on a new scale, and that scale has a total possible point value of 131 points. If you score 100 points or more, then you get the full 25 points for that advancing care information category. You don't get any extra credit for the extra 31 points. Anything over 100 is gravy. But you do have more opportunity then to reach 100 points. And so that's why they've made that a bit more flexible. So I'm going to go through each part of that. So the base score, which makes up 50 points of that category, is essentially a low threshold proof that you are reporting on some basic measures. So you only need to provide the numerator denominator for the percentage-based measures, and that numerator only has to be 1, or you need to just provide the yes-no to some of the other measures that are yes-no measures. There's a couple exceptions here. If you don't do any immunizations or if you don't do any e-prescriptions, then you can report null values on those measures. But otherwise, you need to report all of them in order to get the full 50 points. There are 6 objective categories, and I'll show those to you in a minute, and 9 with an asterisk measures in 2017. So if any of you have dug deeply into the rule, you'll see that it appears that CMS hasn't really addressed modified stage 2. In all of their references of measures, they're all stage 3 measures. So based on that, you may see where people are kind of overcounting the number of measures that are available to report on. So we see that in 2017, they're going to have to address the stage 2 measures as well, and CMS does know that. So these are those 6 objectives. Much of this is information that will be familiar to all of those of you that have been filing meaningful use. But there is some new terminology in here that's different than what was there before. So protect patient health information is the security risk audit. Coordination of care through patient engagement is view, download, transmit, secure messaging, patient-generated health data, which is actually a stage 3 measure. So this is just as an example. These are all of the measures that you will have to report for that base score. So you will have to report the yes, no, or like I said, just a numerator of 1 for each of the percentage-based scores. For the performance score, you're going to see something a little different. So now your performance rate is going to matter for each measure. Again, there's no thresholds to reach. In 2017, they have a specific way of recommending that they're going to do the scoring, so I'll show you that in a minute. But they do suggest that future years beyond 2017, you might see more of a benchmark percentile system in place as opposed to the system that they're going to put there now. So if you score in the 80th percentile relative to your peers, you get a certain number of points. At this point, they don't have benchmarks to measure you against, so going into 2017, there's a different way they're going to do it. They're going to focus on 3 objective categories of the 6 that I showed you on the page before, and pointing out right here, 6 or 8 measures in 2017 per the modified stage 2 or 3 rule. So the way that it's written makes it assume that there are 8 measures in 2017. There are really actually only 6. So on the call I was just on with CMS, they recommend adding in some comments about how to address stage 2 going forward. And these are the measures. So patient access is the portal measure. Patient-specific information is the one that we know right now as patient education. There's view, download, transmit, secure messaging, summary of care, and med reconciliation. You'll see that these other ones right here are stage 3. The clinical information reconciliation is actually comprised of 3 categories for stage 3, so I'm just indicating what we have here right now for stage 2, which is med reconciliation. So now let's take a look at an example of how this works. So starting with the base score, if you get all of if you report everything you're supposed to report, your total possible points is 50, and let's say this particular person got 50. And then let's run through a couple examples. You scored 10% on view, download, transmit. Your total number of points possible for each of those categories, because there's 80 points total and there's supposedly 8 measures, so that would mean there's 10 points available for each measure. You get 1 point. So you just move the decimal over 1, but they're basically having you receive points relative to the exact performance rate that you've received, and decimals do count. So patient education, if they scored 33% in that category, they would get 3.3 points. So you see how this goes. You also then at the end have the option if you report beyond just the immunization registry. So if you report to an additional registry, you get an additional MIPS point. So total that all up, you have 87.8 points, which means you're going to get 87.8% of the 25-point total. So this is ACI's contribution to MIPS, 21.95 points. Okay, lastly, so how are you going to get data to CMS? What's going to be different? So just as the individual and group is different, there is differences in the proposal around what different submission methods will be allowed. So there's not a tremendous amount of detail around the submission methods, like specifications, how that would work, any of those sorts of things, but they do list all of the different available methods for getting the information to CMS. So attestation will still be available, but you'll also be able to send things via other methods as well. There is, just to be clear, even though you can report individual or group, you are not required to attest, or I should say submit the same way for each category. So you can submit different ways in each category. You don't have to submit all the same. Okay, out of breath, spent a lot of time on ACI, so we're going to move over to another very important category, which is the quality category. So quick reminder of how we have it right now. We know that PQRS method selection, the PQRS and CAPS measure values, the CMS calculated measures, the VBM benchmark measures, and peer cohort performance data all together feeds that VBM algorithm, which ultimately gives you that VBM quality score, the one that shows up on your QRUR reports and puts you in a scatter plot and indicates whether you are getting an incentive, or in the safe middle, or getting a penalty. So just like what I did for ACI, and we'll change that. So just like I did for ACI, I want to also point out what's different about the PQRS program. Right now, and depending on the method that you send, but kind of traditional, EHR direct method, is 9 measures. So you have to report on 9 measures. Of course, if you're doing some other methods, there's a different measure requirement. But in general, you're sending 9 measures to CMS. There is a notion of domain reporting within those 9 measures. So you have to, just like in Meaningful Use, how you have to cross multiple domains, the same concept exists in PQRS, which can cause you to perform better or worse depending on how many measures you have in any particular domain. So that domain layer can really have a pretty significant impact on your overall VBM score. So that's important. That's an important point. There are some methods that only require partial payment volume. So right now, the measures group, you have to use 25 patients. Some of the registry is 50% of your patient base. So you don't have to use all of your patient volume in order to send things to CMS. There's something called the ACQS or SQCS score, which is what I was talking about before when I was talking about the VBM algorithm. So there's a score that's calculated for you that then is used to determine whether, again, you're neutral, get an incentive, or lose money. So this every point matters, or linear scale of getting money, losers taking or winners taking from losers, that's all different. There's also, at this point, when you get those averages for those benchmark values for each of the measures that you're reporting, there is a single measure benchmark across all reporting measures. So no matter which way you're reporting, CMS is making an average based on that. So it doesn't matter, everybody's going to be right now compared to that same benchmark. And then currently there's a requirement to declare if you're going to do GPRO by June 30th. So let's talk about what's different then. So they've reduced the requirement of 9 measures down to 6, with the requirement that within those 6 measures, there's 1 cross-cutting measure and 1 outcomes measure. So they'll make sure that you have to meet that requirement in doing that. The idea of domain reporting has been completely eliminated. So you can really then zero in on those measures that you want to concentrate on without having to put in that additional layer of making sure you're covering 3 domains. The requirement right now in the NPRM is that that reporting has to be 90% of patients across all payers. So these methods before that required a small number of patients, as we see it, would likely need to change significantly in order to meet this requirement of 90% of all patients. The ACQS SQCS score is now replaced with decile calculation. So you'll see that in the scoring. So I mentioned before that you are going to be scored on a compared to your peers. So we'll talk about that. The neutral impact goes away. There is no possibility of a neutral impact. You will either lose or gain in this new program. And then rather than a single measure benchmark across all reporting measures methods, there's going to be new benchmarks for each reporting method. I personally think this is a very good thing because then you're really being compared correctly, apples to apples, as opposed to being compared to people that are reporting measures a very different way. And then the last point about the declaration of GPRO reporting, as you saw, there's a tremendous amount of impact of whether you report individual or group for MIPS overall. So to make sure that you aren't forced to that requirement early, mid-year, before you really know performance for your organization across all 4 of these programs, they do indicate that you will not have to declare that anymore. So you're not going to have to make that declaration by June 30th. There is an exception. If you're doing GPRO web interface, I believe you still do need to make that declaration. And if you're doing CAPS for MIPS, you do need to also indicate that you're going to be doing that. A few other changes. The QRUR that we right now for the VBM program, that is going to be replaced by a new MIPS feedback report. Although we do see that it's likely still going to be published about 9 months after the performance year. March 31st, they've aligned that now, so there's no slightly different, I should say, reporting deadlines for the different methods for submitting data too. So there's a March 31st data submission deadline for everybody. Okay, so now let's talk about the quality scoring algorithm. And I've greatly simplified it, recognizing that there are going to be a number of different reporting methods and quite a bit more that goes into this in the end. So each measure is going to earn points based on their decile value versus the benchmark. So if your 74% measure rate is greater than 60% of your peers, then you are in the 60 to 70th percent decile, and you earn 7 out of 10 points. So basic scoring relative to being graded on a curve, once again, how you're performing relative to that benchmark value. You're going to add up all of the points that you have scored for each of your measures. You're going to divide that by the maximum, and then you're going to get that quality score as a percentage and multiply it by 50, or the 50 MIPS points that are available that contribute to the composite score. So very similar to ACI in that category. So you're just going to add them up and then apply that to 50. There is also the ability to earn some bonus points. So besides this, kind of measurement relative to your peers on the measures that you're reporting, there are a number of additional places where that you can earn bonus points. If you get anything above 100 based on all of those bonus points that you earn, you're still going to only get the maximum 50 points. So again, similar to ACI, you can get more than the 100 points of that category, but you're still only going to get your maximum. So just a demonstration here then of how that might work. So you're sending in your 6 measures, 10 possible points for each of them. Here you're going to get 8, 7, 5 points depending on those percentiles that you've scored. You can get your bonus points available. Here's a couple examples of where you get bonus points. You can get bonus points for choosing high priority measures, by doing caps for MIPS, and by doing what they're calling end-to-end e-reporting. So if you're able to do a single electronic submission for all of MIPS, then you are also going to be able to get bonus points. So all of that together in this example that I'm showing indicates that of the possible total 60 points, they got 58% of the total. So that 58% times 50 indicates that the quality score contribution will be 29.2 points. The method of getting data to CMS is pretty much the same as it was for PQRS and value-based modifiers. So you will submit data in the same formats. Again, there isn't much detailed information about whether or not there are some things that change or what kind of certification would be required or any of those kinds of things. But those are the methods that CMS has indicated in the NPRM. Okay, in the last little bit of time that we have, I'm going to take us through the last category for which all of you have control over, and that's the clinical practice improvement activities category, or 15% of the score. So what exactly is CPIA? A couple examples, and there are numerous. Care coordination, so anything any activity that demonstrates improved care coordination would be a clinical practice improvement activity. Things that have shared decision-making, safety checklists, expanding practice access. Expanding your hours is a clinical practice improvement activity. So there is a very long list. Right now the list is 90. If you look in the NPRM under Table H as in Harry, you'll see the list of 90 possible activities in there, and then you can get additional credit for more activities. In that list that's published, it'll also indicate the overall weight value of score. So it doesn't actually give you a number, but it actually indicates whether they expect that activity to be a high weight, a medium weight, or a low weight. So if there's any specific information that you have or information you want to make sure that you share with CMS regarding those kinds of activities, then that's absolutely an area where comments should be sent in. You also get full credit for a patient-centered medical home. So if your TIN is a patient-centered medical home, you're going to get full credit for that category. And if you are also participating in an APM, you're going to get a minimum of half credit. So you will get some additional credit for doing that if you are in that as well as MIPS. So just to summarize where we land with everything again. So quality category, again, depending on group size, you have a maximum of 80 to 90 points possible in that category. So like I said, there were the 6 measures, but there's also ability to earn additional points. So that's your maximum based on the group size, and that's going to be 50% of your score. The advancing care information has a maximum of 100 points that can be scored, can be earned, and that will impact your MIPS percentage of your MIPS score by 25%. CPIA 60, contributing 15%, and then of course the cost category. Okay, so before we get into questions, I'm just going to do 2 quick things, and that is first, just talk briefly about things that you can do right now. So one thing that we've seen with our clients is that there's an incredible amount of education that needs to happen, and particularly at the senior levels of the organization about this financial impact on this pretty significant program. So that kind of education needs to start pretty quickly. We recommend that you estimate your MIPS score. So there's some tools coming, and we have a MIPS calculator on our website. There's going to be some updates to that and some additional things available to you so that you can do some of those estimates out using our tools. So the other is to try to optimize what you're doing right now. We often refer to 2016 right now as the training wheels year. So even if you perform at the threshold values that CMS has indicated for all of your ACI measures, you're still going to perform well below those 100 points. So maximizing your performance rates for all of your measures will be important. And then the same, of course, goes for PQRS and BBM, because the level of monitoring you're going to have to be doing going forward is going to increase significantly. Goes without saying, all of this means you're going to have to evaluate staff and resources and organizational structure that goes with this. Having been in meaningful use since the beginning and then more recently in PQRS, we know that they often live in different departments completely. So kind of bringing that stuff together is also going to be important. And then make sure that you know what any of the calendar year 2016 deadlines are that are going to impact calendar year 2017. And then just lastly, just want to give you a few different resources. All of these are on our website, saignite.com, so you can navigate your way to them just by going there. There's going to be there's FAQs about MACRA, there's FAQs about MIPS, there's the free financial calculator that gives a pretty detailed overview of how to run through that and give yourselves a bit of an over-under on where you stand. And then, of course, this. So we have our monthly presentations, and any past ones are also posted on our website. Lastly, and I referenced this as we were going through the presentation, I a few times indicated that people should be submitting comments to certain aspects of the rule. So I indicated that relative to the 6 measures for ACI and for the clinical performance improvement activities category. We are currently in the comment period, and we at SAIgnite are trying to collate information that we're hearing out in the field and submit comments for review. So if you're not already a member, you can join our LinkedIn group. There's no ads, nothing else in it. You can just join the group and then based on and submit information through that MIPS group, and then we'll collate everything together and submit it. Of course, if you want to submit things on your own, we of course think that's important to do as well. So that is it, and I was perfectly 45 minutes in. So before we get started on Q&A, I did want to I'll let you know there's another person on the line with me from SA Ignite. So Denise Briere is our product manager for this program, and she has additionally read the regulations and often knows more than I do on it. So hopefully between the two of us we can answer your questions as they come in. So thanks, Denise.
And I think she's on. Is she on mute, Denise?
Oh, I just unmuted myself. Can you hear me?
Oh yeah, we can hear you. Can you hear me?
Yes, thank you.
So before we begin, getting a ton of questions coming in from the attendees. A copy of this video and recording will be sent out. I usually get that out within within 24 hours. As Beth said, you'll be able to find a copy of this recording on their website. You can also find it on our High Tech Answers YouTube channel and healthcarenowradio.com YouTube channels as well. We do have a ton of questions. If we don't get to your question, and we will not get to the vast majority of these, Beth can be emailed at beth@saignite.com. So with that, I'm going to take a couple questions from the registrants and then a couple from the live audience. First and foremost, as a large organization that runs both a Medicaid MU program and Medicare, how do we do both under MIPS?
Fantastic question, and probably one of the things I noticed right away when I was looking at the rule. This is going to be challenging. If you will be subject to basically two separate set of rules. The Medicaid program will run just as it exists, and in order to earn those incentive dollars that likely still, are there for you, you will have to submit for your attestations just like you do right now under the same exact meaningful use rules. The thing that I think is incredibly or additionally tricky is that you could have people that are both. So in the existing program right now, if you attest for Medicaid meaningful use, you are able to avoid Medicare penalties. Because they've completely separated the programs, that connection does not exist. And under the current proposed rule, comments welcomed, under the current proposed rule, you will have to report to both. So you will have to report to both in order to avoid Medicare penalties for those people that are Medicaid eligible but yet still have Medicare charges.
And just to remind the audience, the Medicaid MU program is scheduled to go through 2021, right? Will physician specialists who practice in a hospital setting be included in this rule?
So this one is a little tricky. Those people that are still part of the eligible hospital definition will remain part of the eligible hospital definition. But for those people that are hospital-based, that kind of do that 90% threshold year to year are checked, they will be part of MIPS, but they could be subject to the kind of override that says that you would report that the ACI category would be 0%. So you still are required to be part of MIPS, but you could get a waiver from one of the categories at the very least.
Can you please discuss the relationship between meaningful use stage 3 and MIPS?
So I actually took an attempt to do a little crosswalk. I know Denise did the same thing. Stage 3 and MIPS should be the same, with the caveat that the different, the names of the measures as well as the objective categories have changed. So you will notice if you try to do the mapping yourself that some of that information is kind of hard to follow. So it should be stage 3 measures that are reflected in the MIPS program.
And then also I would just add, if it wasn't clear, that stage 2 measures are valid for reporting in 2017 because it is optional in 2017 whether you report stage 2 or stage 3.
Can you, and you talked a little bit about reporting as an individual versus group reporting, will we be able to change between individual and group reporting in subsequent years? Can you go back and forth?
Denise, I'm going to let you take this one.
Yes, you can. And because there's not a June 30th deadline going forward, you don't have to make that decision in advance of the reporting period. So, or in advance, well in advance of the reporting period, I should say. You're going to have to make it at some point in advance so that you're just prepared for reporting. But each year you can change your decision on whether you would report as a group or report as individuals.
If some providers under obviously one organization, report to a registry for the extra bonus points, but not all providers, and you report ACI as a group, would you still get some bonus points?
Well, first of all, you can't do that. If you have to report as a group under all 4 categories. So if you decide that you're going to report as a group to a QCDR, may have been what you're referring to, you report as a group to the QCDR, and then you have to report as a group for the ACI category and the CPIA category, and then the resource use category you will be judged as a group based on the measures that CMS calculates. And I believe, did I answer the question fully? There might have been a second part of that question I didn't quite.
Yeah, no. Well, they were just wondering if they could get, I guess, partial bonus points. A little bit.
Yeah, there is a bonus point in there somewhere for reporting to a specialized registry, but you still have to do it either as a group or as an individual.
How do behavioral health providers, social workers, psychologists, et cetera, participate in MIPS, PQS requirements, et cetera?
Well, if you are in the category, in some of those clinician types, you're not actually required to report to MIPS in the 2017 or the 2018 program year. That may be expanded. If you're a behavioral health person who happens to be a physician, then you are required to report under MIPS. So I don't know if there's a more specific question there on what type of quality measures a behavioral health person would submit, but it is required to report under MIPS if you fit the clinician types and meet the thresholds.
Got it. Do you guys know where, they're so cute when they answer questions, do you guys know where I can get a list of outcome measures for the quality category?
So the outcome measures, there's actually a document that CMS has published on the outcome measures that are calculated by CMS. They're referred to as the, I think they're referred to as like the composite measures. We can actually potentially email that out to people, Carol, the document that CMS has published.
That'd be great.
If you're referring to the outcome measures that are specific to actually quality measures, those are actually identified in some documentation from CMS as well. So there's probably 2 separate documents we can email out to people as a reference.
That'd be great. I can include it when I send out the slides and the recorder, the recording of this presentation. Can you review again when you think the final rule will come out?
Well,
we know reporting starts in January 2017. How much time will there be?
I know. You know, I would be making a guess just like everybody else. I will say that one of the things that we're doing as a company is staying as close to those rulemakers as possible and as close as possible to all of the associations that spend a lot of time with the rulemakers so that we can get hints of that. Tom, our founder, did correctly predict the release of this NPRM, so we're hoping that he might go 2 for 2 in 2016 here and also predict that. But the only thing I can say is what is actually in the regulation, which says it has to be published by November 1st.
So it could be, you have 2 months. Yeah. A comment. I've listened to almost all of the CMS webinars, and this has been the best so far. SA Ignite rocks. Please tell me that you'll be doing a webinar on APMs.
You know what? I'm glad that you actually said that because I do believe that one of these future ABCs of MIPS is going to be specifically on APMs. There's a reason we didn't take it on. It is just has its own life, and I think it would detract from all the focus on MIPS that we wanted to make sure we covered in this presentation.
And I don't know if this is covered in the NPRM. How will hardship exemptions affect the MIPS score? Or MIPS score?
So the way that I see it right now is the hardship exemptions for meaningful use, and that's the category I'm thinking of when you're asking the question, is that they will just then get a 0 on that category. So, and that would then, of course, weight the other three categories higher. So a hardship exemption, the idea of it is it specifically goes away with the new regulation.
So it's your score or not your score.
Correct, and you will have to submit something. I should point that out. So even though, so it's probably, I'm going to use the term rebranding again. So it's probably another rebranding of hardship exemption, but you do have to submit to request to have that category counted as 0%. So I believe that that's how they'll handle it, is basically for the same kind of reasons that are available in the hardship exemption, they'll put those same kinds of reasons in for putting a lower weight on a category.
Got it. We're getting quite a few questions about what if we belong to an ACO, and my guess is that we're going to be looking at that when we talk about APMs in a future event.
Comment about if you belong to an ACO, in order to not also have to report MIPS in the MIPS categories, your ACO has to be considered a risk of taking on enough financial risk for CMS to designate you as a qualified APM that therefore doesn't come under the MIPS umbrella. And the financial risk is fairly high. So that will be covered in a separate session, that just because you're part of an ACO doesn't mean you're exempt from MIPS.
It's an EHR vendor question, do you think there will need to be modifications to the ONC 2015 Certified EHR Technology Edition? That's, of course, providers are using the 2015 edition for Stage 2 and Stage 3. Yeah. What do you think they'll be revised?
Yeah, I don't know whether or not let's put it this way. I think it likely makes sense, especially because of the way that they indicate all the new different kinds of submission models. They could, I would assume, throw in some certification related to some of that submission. I don't know is the short answer, but I can see many things in the regulation that would indicate that you might want to relook at them.
Just right. And just again to remind everybody, this is the Notice of Proposed Rulemaking we've been going over that Beth presented and getting questions on. So we are just about out of time with today's presentation, and we will be, again, sending out the recording and the PowerPoint presentation. I want to go back to the slide where various resources are, because people are asking me, so bear with me. Mm-hmm. There we go. So here is the list of resources again. Go to SA Ignite's website. They've got their MACRA FAQs. They've got the MIPS FAQs. They do have their free financial calculator, which you can download. And of course, you can catch previous recordings of all of our ABCs of MIPS on SA Ignite's website and on our High Tech Answers and Healthcare in Our Radio YouTube channels. Beth, Denise, thanks so much for providing your expertise and insight. We'll definitely look forward to the presentation on APMs, just based on the number of questions that we're getting. And again, if we didn't get your question and we didn't get to many of them, feel free to email Beth at saignite.com. Beth, I hope that's okay that I just threw your email out under the bus.
No problem. No problem.
And thanks to everybody for taking their time today, and I will get the recording of PowerPoint out certainly by tomorrow. And thanks again, and we'll see you on next month's ABCs of MIPS.